Welcome to the series where I review the 2025 AACE Consensus Statement on the algorithm for the evaluation and treatment of adults with obesity or adiposity-based chronic disease. This is Endo in a Bite, where I break down complex concepts into bite-sized pieces you can actually remember. Today, we're talking about individualizing obesity pharmacotherapy. So if we step back for a moment, everything we've covered so far, staging, complications, cost, access, step therapy, this all leads to one unavoidable reality. There is no single best obesity medication. The right medication depends on the disease in front of you, the organs involved, the risks you're trying to avoid, and what that specific patient can safely tolerate and sustain. And that's where obesity care stops being algorithmic and starts being clinical. So in this final section, I want to discuss today how to individualize obesity pharmacotherapy, condition by condition, based on benefit, risk, contraindications, and monitoring. First, we will talk about individualizing obesity pharmacotherapy, because this is where prescribing stops being theoretical and starts becoming patient-specific. This framework isn't about which drug causes the most weight loss in isolation. It's about matching benefit, risk, monitoring burden, and contraindications. Before starting, I will say that this portion will be best retained if you have the table in front of you, and the table goes straight to your inbox if you have signed up for the newsletter. First, I'm going to talk about individualizing obesity pharmacotherapy. I'm starting with diabetes prevention. In diabetes prevention, orlistat provides benefits strictly through weight reduction. Phentermine has insufficient evidence to be preferred in this setting. Phentermine with topiramate extended release provides benefit via weight reduction. Naltrexone extended release with bupropion extended release, again, has insufficient evidence to be preferred. In contrast, liraglutide, semaglutide, and tirzepatide all provide benefit through weight reduction plus incretin effect. Now, type 2 diabetes. Here, orlistat continues to provide benefit via weight reduction. Phentermine still has insufficient evidence to be preferred. Phentermine with topiramate extended release provides benefit via weight reduction. Naltrexone with bupropion extended release also provides benefit via weight reduction. And again, liraglutide, semaglutide, and tirzepatide provide benefit via both weight reduction and incretin effect. Next, let's discuss hypertension. Here, safety considerations start to matter much more. With hypertension, orlistat provides benefit via weight reduction. Phentermine requires monitoring of heart rate and blood pressure, and it is contraindicated in uncontrolled hypertension. This is important to remember. Phentermine with topiramate extended release also requires monitoring of heart rate and blood pressure, although it's important to note that blood pressure benefit has been observed in clinical trials. Naltrexone with bupropion extended release again requires monitoring of heart rate and blood pressure, and likewise is contraindicated in uncontrolled hypertension. For liraglutide, semaglutide, and tirzepatide, BP benefit has been observed in trials, but heart rate monitoring is still indicated. Now let's discuss AACVD. In AACVD, orlistat has insufficient evidence to be preferred. Phentermine is contraindicated outright. Phentermine with topiramate extended release can be used with caution with explicit monitoring of heart rate and blood pressure. Naltrexone with bupropion extended release also requires monitoring of heart rate and blood pressure. Liraglutide has demonstrated prevention of AACVD in patients with type 2 diabetes. Semaglutide has demonstrated prevention of AACVD more broadly. And for tirzepatide, evidence in type 2 diabetes and obesity is pending. Now let's move to MASLD. For MASLD, orlistat, phentermine with topiramate extended release, and naltrexone with bupropion extended release all have insufficient evidence to be preferred. In contrast, liraglutide, semaglutide, tirzepatide have all shown benefit observed in clinical trials. Now let's address mental health considerations, starting with depression. For depression, orlistat and phentermine have insufficient evidence to be preferred. Phentermine with topiramate extended release, naltrexone with bupropion extended release, liraglutide, semaglutide, and tirzepatide all require appropriate monitoring. For anxiety, orlistat again has insufficient evidence to be preferred. Phentermine with topiramate extended release, and naltrexone with bupropion extended release require appropriate monitoring. Liraglutide, semaglutide, and tirzepatide have insufficient evidence to be preferred in anxiety. Now let's talk about renal disease. Here in renal disease, dosing limits and adverse effects are critical. In CKD, orlistat requires monitoring for oxalate nephropathy. Phentermine has insufficient evidence to be preferred. Phentermine with topiramate extended release should not exceed 7.5 milligrams/46 milligram per day. And then naltrexone with bupropion extended release should not exceed 8 milligrams/90 milligram twice a day. Liraglutide, semaglutide, tirzepatide demonstrate benefit in type 2 diabetes with the important caveat to avoid vomiting and volume depletion. Now, in severe kidney impairment, orlistat still requires monitoring for oxalate nephropathy. Phentermine with topiramate extended release, and naltrexone with bupropion extended release requires consideration of urinary clearance of the drug. Liraglutide, semaglutide, and tirzepatide again require avoiding vomiting and volume depletion. Now, renal calculi. With kidney stones, orlistat is associated with calcium oxalate stones. Phentermine has insufficient evidence to be preferred. Phentermine with topiramate extended release is associated with calcium phosphate stones. For naltrexone with bupropion, as well as liraglutide, semaglutide, tirzepatide, there is insufficient evidence that they should be preferred. Let's talk about hepatobiliary impairment. In hepatobiliary disease, orlistat requires monitoring for cholelithiasis. Phentermine should not exceed 8 milligram per day. Phentermine with topiramate extended release should not exceed 7.5/46 milligram per day. Naltrexone with bupropion extended release should not exceed 8/90 milligram daily. Liraglutide, semaglutide, tirzepatide all require monitoring for cholelithiasis. Finally, severe hepatic impairment. In this setting, orlistat, phentermine with topiramate extended release, and naltrexone with bupropion extended release are not recommended. For liraglutide, semaglutide, tirzepatide, there is insufficient evidence that they should be preferred, rather than a strict contraindication. Two universal points apply across all of this. First, all obesity medications are contraindicated in pregnancy and breastfeeding. Second, when BP benefit is mentioned, it reflects the fact that BP pressures were significantly decreased in clinical trials. So the takeaway is this. This approach isn't about choosing the best obesity drug, it's about choosing the right obesity medication. One that aligns with comorbid disease, minimizes harm, respects physiologic vulnerability, and anticipates what needs to be monitored over time. That's what true individualized obesity care looks like. This was another bite-sized episode of Endo in a Bite, and it also brings us to the end of this obesity series. In the last several episodes, we've worked through the AACE consensus statement, the algorithm for the evaluation and treatment of adults with obesity or adiposity-based chronic disease, the 2025 update. The bottom line is simple. Obesity is a chronic disease. This is chronic disease care, staged and individualized, with therapy matched to complications, patient context, and real-world constraints like cost and coverage. If you want the key pearls to stay fresh, remember to visit www.easyendoprep.com to sign up for the weekly newsletter and have the takeaways delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and LKA or ABIM exam prep. Thanks for going through this document with me, one bite at a time.